So my name is Carel Le Roux. I'm a Professor of Metabolic Medicine at University College Dublin. I think that we have not understood that obesity is a disease, and therefore if we get it that it's a disease, then suddenly we'll start treating it like any other chronic and complex disease. And I think this understanding changes how we approach the disease as such. And therefore we are thinking about the etiologies of a disease, the symptoms of a disease, the signs and the complications. And what we want to do with our interventions is change the symptoms. We want to make people feel less hungry, and we want to make them feel more satisfied. And once we address the symptoms, then everything else is like rolling downhill. I think that legislation can be a very helpful tool, but it has to be used as a scalpel rather than a big sledgehammer. Therefore, we need to know what we are trying to achieve. I think it's very important that we legislate against the stigma of obesity, because discrimination is not only cruel, it's also not very sensible if we are trying to treat a disease. I also think that it is very reasonable to legislate that we actually have more care for people with obesity, because that's what we do. If people have diseases, we care for them, and that's how we improve that. If we are going to use legislation to change other factors that we are not sure is driving the disease, then it may be counterproductive. What we are learning about obesity is that it's not only one disease, that it's a multitude of different diseases. And therefore we see that diet approaches are incredibly helpful for a subset of these obesity diseases. What we're trying to do is to try and find out which patients will respond to the diet approaches, and we need to continue those approaches in those patients. If the diet approaches don't work, we need to change, and we need to try to find other treatments. There's not one solution that fits all. And at the moment we just don't have the diagnostic capability to diagnose who will respond to a diet, who will respond to medication, or who will respond to surgery. So up to that point we have to use the treatment such as diet approaches more often, and therefore discontinue it if it's not working, but continue it when it is working. We will start treating obesity in the way we treat cancer. Cancer is not one disease. The difference in the treatment between esophageal cancer or leukemia is there for everybody to see. In the same way, once we understand that obesity is multiple different diseases, we will see that we need more treatments, not fewer. And there's not one treatment that fits all. I think it's very important to address the stigma of obesity in the first place, and to make people aware that obesity is a disease that needs to be treated like any other disease. Once we have done that, I think we need to become better at diagnosing what type of obesity people have, and therefore work out what people are going to respond to. We need to use more diet approaches, because certainly there's many people that can benefit from that. Ideally, we need to find out which patients they are before we can start our approaches. But we're not there yet, but we are able to say if people start a diet, if they are responding, continue. If they're not responding, let's change either to another diet approach or to medication.